The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Corporate Pamela Ohaneje Abai, Corporate Relations Manager, Limi Hospital Group. I'm here today to briefly introduce us to the edition we're having today for the pediatric webinar. We are going to be presenting on acute symptomatic seizures in children. But before we go into that, I just want to give a brief introduction about the Limi Children Hospital. The Limi Children Hospital is an arm of the Limi Hospital Group, located at number 39 Ademola Adetokunbo Crescent, Wuse 2, Abuja. Is a designated specialty hospital for pediatrics, neonatology, and general medical care for children. The Limi Children Hospital was commissioned about 6-7 years ago, and we have focused on giving major care to neonates and children in general from 0 to 17 years. Why consider working with Limi Children Hospital? We are specialized in general pediatrics, pediatric hematology, pediatric dermatology, neurology, cardiology, endocrinology, gastroenterology, and ENT. We also have child and adolescent psychiatry. So far, I just wanted us to know what we do at the Limi Children Hospital, how you can reach us in case you have cases you want to share with our doctors, or you have a patient you want to refer to the Limi Children Hospital. Our mobile numbers are available, and we are open to research, partnership, and collaboration with other hospitals, of which we have ongoing MOU with some government hospitals so far. And we are very open to working with you from whichever hospital you are working from. Once again, my name is Pamela, and I'm going to hand over to Dr. Nwala Gabriel and Dr. Fatima Kanti. Thank you so much for having me. And then we're going to start right about now. Thank you.
Very good afternoon, lovely participants, teachers, colleagues, distinguished ladies and gentlemen. So as Ms. Pamela had already told us, I'm Dr. Nwala Gabriel, a consultant pediatrician with Limi Children's Hospital, and with me
Yes, Dr.
The-
Fatima Kanti, Pediatric Medical Officer.
Okay, so sorry, let me start by apologizing for starting a bit behind schedule. We had some technical issues, so we will take off right away. Fasten your seatbelt and enjoy the jolly ride. Our discussion today will be on acute symptomatic seizure. Seizures in children generally can be classified into three major categories: either febrile seizure that makes up 60% of most febrile seizures, or acute symptomatic seizure, where we will this discussion on this afternoon, and the third one is epilepsy. So any child convulsing can be either from one of these three things. So I think by the end of this discussion is our desire or our expectation that we should be able to recognize acute symptomatic seizure, as well as know how to manage cases of acute symptomatic seizure when they present to us in our practice. So, Ms. Pamela has told us a bit about the LIMI hospital group, made up of three expressions: the multi-specialty expression at the central area, the internal medicine arm, cardio care, and LIMI Children Hospital, from where this discussion this afternoon is emanating from. So all these have been spoken about, so we'll go into the meat of the matter.
Yeah, acute symptomatic seizure in children, recognition and management. So most people know or have a general idea of what seizure is. Some people even know how to know some of the causes of seizures. Others are very good that they even know how to manage some seizures. But the question here is, are all types of seizures the same? Is it every single type of seizure that will be managed by medical management for life? Or is there seizures that can just be managed primarily with medication, and then we don't need to be on medications for life? So these are the questions we plan on answering at the end of this presentation.
Okay, the discussion will be under the projected outline. So we'll start with the case vignettes. One of the cases we managed at LIMI Children's Hospital.
So we had a few weeks back, we have an 8-year-old non-HBSS who presented to the hospital with stomach and back pain of 6 hours and 2 episodes of vomiting and presentation. So 2 days into admission, child had a generalized tonic-clonic seizure that was aborted spontaneously. On examination, the child was crying in painful distress. There was no fever. Central nervous system examination was normal. There were no abnormal findings. SpO2 was 86% at room M, and other systems were all stable.
Okay. With intranasal oxygen, the oxygen concentration improved to 96%, and the seizure aborted. So we want us to also know some of the key investigations that were done, including a full blood count that showed leukocytosis with neutrophil predominance, and the PCV was showed moderate anemia. The blood film for malaria parasite was positive, demonstrated as sexual forms of malaria P. falciparum, and the random blood glucose was normal. The HPLC HB quantification was requested, but due to some HMO related issues, was not done. However, the transcranial Doppler scan that was requested showed normal velocity of 50, mild vasospasm of the left middle cerebral artery, and the other findings were essentially normal. Okay, so at this point, we want to ask our participants to put up in the chat box what they think the likely diagnosis here is. What do you think was responsible for the child's seizures? What are two other differential diagnoses that could have also presented the seizures in this index. What are the principles of management? Supposing you had a case like this in your practice, what would you do if you had such a case? Now, what would you advise the mother of this child to do to prevent recurrence of these seizures? So while we go on with the presentation, I expect us to put up our answers. We'll be looking at the answers in the course of the presentation. But I can assure us that by the end of this presentation, we'll be able to know what the diagnosis actually was and what could be done to ensure that this child goes home without any sequelae whatsoever, as well as the mother knowing what to do in case the child, so that the child doesn't have a recurrence of the seizures.
Okay, so before we talk about our main topic, which is acute symptomatic seizure, let's have a general overview of what seizure is. So in general, seizure is an uncontrolled burst of electrical activities within the brain. That is what we call seizure. So electrical impulse enables the brain to communicate with the spinal cord, nerves, and muscles within itself. So when we have any sudden burst of electrical activities, increase in electrical activities above the normal electrical activity that we expect to see, that's what we define as seizure. So here, seizure is defined as a sudden uncontrolled burst of electrical activities in the brain. Our normal brain function requires an orderly, organized, coordinated discharge of electrical activities.
Okay, so let's try to bring it down a bit. Let's not sound so technical and all. So there are normal signals that take off from the brain. The nerves, the neurons are the units of every signal that emanates from the central nervous system. Now, if one nerve sends a signal, this signal is transmitted to the next neuron or the next nerve cell, and it can be carried all the way from the brain down to the target organ that will bring about a movement. Now, when these signals are now more than what it should be, and the person's voluntary control cannot regulate how these signals are sent, then you have a child that is moving the body, abnormally. The movement is not, emanating from the child's conscious will, and these movements are not controllable. Now, when you have such an abnormal burst of impulses or signals leading to some abnormal movement, this movement can be convulsive in that the muscles are actually moving. It can also be autonomic, in which some autonomic functions like the heart rate, bowel movement, vomiting, and loss of bladder and bowel, continence can be the manifestation. It can also be psychic, it can also be sensory. Maybe person perceives some very bizarre sensations, smells, flashes of lights, and the rest. Now, any of these manifestations that emanate from an abnormal signal from the central nervous system, one can say that that child or the person in question is having a seizure. The seizure can be motor, it can be sensory, it can be autonomic, it can be psychic. So this is just the overview for us to understand what seizure actually means. I believe we are all following. Okay, so let's just look at briefly the pathophysiology of seizures. Now, in acute symptomatic seizure, we'll have to now narrow down our discussion to the subject matter, which is acute symptomatic seizure. There are seizures that are unprovoked, which we call epilepsy, recurrent unprovoked seizures. Then we also have febrile seizure. where fever is the culprit, what is responsible for the abnormal features you find, happening in children between 6 months and 5 years of age. Then you now have another categorization that the International League Against Epilepsy, have been able to come up with. Now, acute symptomatic seizure is a kind of provoked seizure. There is something that underlies the abnormal movement or abnormal features that you see. So if there is any etiologic factor, there is something you can trace as being the reason why the child convulsed or why the child had a seizure. That is the first point you see in the pathophysiology. That's the etiologic factors. Could be hypoglycemia, it could be hypoxia, like in this index, the child's oxygen saturation was reduced. So hypoxia can cause an abnormal discharge electrical activity in the brain. So other things like electrolyte imbalances and other things like electrolyte imbalances, like hyponatremia, hypernatremia, hypocalcemia, hypomagnesemia can all cause a seizure. So by the time you're able to establish what led to the abnormal movement and you correct it, the child will be fine. Like in this index, we didn't have to give any anticonvulsant. We just took care of the low oxygen saturation by giving intranasal oxygen, and the child was fine and never had another episode of seizure. Now, the underlying etiologic factors will affect the neuronal membranes integrity. So, in our basic sciences, what actually brings about an action potential is, movement of, ions, electrolytes across the membrane. There are those that are predominantly intracellular, and there are electrolytes that are predominantly extracellular. So once there is an influx of things like calcium, for instance, it will lead to some action potential, influx of sodium, efflux of potassium, will bring about an action potential, which, if it happens in the neuronal cells, will lead to an abnormal signal or will lead to an action potential, depending on whether it's normally occurring, or whether it's actually an abnormal occurrence. So this will now lead to firing of the signal or the electrical activity, increased frequency of firing, increased amplitude of firing, which we now see as the abnormal discharges presenting as abnormal hand movement, be it tonic, be it tonic-clonic, be it myoclonic, be it atonic, whatever manifestation that is abnormal that you're seeing that is not controlled by the conscious will of the individual, the child, will lead to these abnormal neuronal activity that will eventually or ultimately present as a seizure. In this index now, if you had followed the case vignettes, you know that here was due to hypoxia. Okay, so let's see if we have some answers. Okay, Dr. Chukwudi Obineche has listed 3 differentials: meningitis, cerebral malaria, hypoxia. Okay, hypoxia, very correct. The amount of parasitemia that will give you cerebral malaria is not like the 1+ that we saw. Then meningitis may be possible, but this is an 8-year-old. Yes, so an 8-year-old should have had well myelinized neurons, so there should be signs of meningeal irritation if it were to be meningitis. So meningitis, it's unlikely, even though there is one can argue that there was some level of sepsis due to the leukocytosis, but you can also have sepsis associated encephalopathy being a cause of seizures, or which can fly here, but not meningitis, because there were no elicitable or demonstrable signs of meningitis. Halimat, okay, says cerebral malaria is most likely that we've mentioned why cerebral malaria might be unlikely here. Okay, cerebral malaria, let's just dissect cerebral malaria more. Cerebral malaria, it's one of the components of severe malaria. You know the age, the categories of children that will have it: 6 months and 6 years. This child is 8 years. That is, the child is beyond the upper limits of the likely age bracket that you'll be thinking of cerebral malaria. Although cerebral malaria can occur in somebody that just came into a malaria endemic area, but this child has been living here with us in this country or this way, so we never expected that the child that has been here with us all this while will have cerebral malaria. Differential diagnosis of acute bacterial meningitis is possible. Acute seizure disorder. Okay. I think this Halima might belong to there are newer classifications now. So is either you're talking about acute symptomatic seizure, possible, secondary to malaria, secondary to sepsis, or secondary to any other acute causes of febrile illness. Management, okay. So what is needed here most that we did that helped the child was actually oxygen. The SpO2 was 86%. So the hypoxia was responsible for the child's seizure. So after it was sorted out, the child's seizure didn't recover. Okay, so let's move on with the presentation. Other contributions will be looked at because of the presentation. So
like we said, seizure, we have 3 classes of seizures. We have acute symptomatic seizure, we have epilepsy, and we also have febrile seizure. So how do you differentiate them? For example, in acute symptomatic seizure, the difference between it and epilepsy is having clear identifiable cause. It has an etiology, an underlying cause that caused the seizure. And then acute symptomatic seizure, unlike epilepsy, it has higher rate of mortality because of the acute onset of the disease. And acute symptomatic seizure as well does not require long-term treatment with anti-epileptic medications, unlike epilepsy. We just use the anti-epileptic drugs to just abort the seizure if it doesn't abort itself spontaneously. So acute symptomatic seizure, which is also known as reactive seizure, provoked seizure, or situation-related seizure, is defined by the International League Against Epilepsy as a clinical seizure occurring in close temporal relation with an acute central nervous system insult, which may be metabolic, toxic, structural, infectious, or inflammatory.
Okay, like in this index, let's look at the causal relationship between the case we presented and the subject matter. In this index patient that we presented, the child had a metabolic cause of the seizure. In this instance, hypoxia. So hypoxia is an acute insult to the brain of a child. So once there is hypoxia, the brain will just, Newton will say action and reaction are equal and opposite. So once there is an insult to the child's brain, the neurons will respond by throwing an abnormal signal, which we see as a seizure. So I think we can relate with what the subject matter is, as in what the meat of the discussion is, and relate it with the case that we presented. So acute symptomatic seizure, because it's a new coinage, is something that the International League Against Epilepsy has been able to, bring up to help categorize seizures from known etiologies, seizures from factors that provoke the abnormal signal. So if we are able to note that this is a new coinage, something that came up in the last 1 or 2 decades, then that might explain why there are fewer literature to help us know how common this condition is. The incidence has, from the few reported cases, range between 29 to 39 cases per 100,000 of population in a year, and 40% of all afebrile seizures are caused by acute symptomatic seizures. Hypoglycemia, electrolyte imbalances, other causes of acute cerebral insult, even sepsis, for instance, can give rise to seizures. So I want to note here that 60% of seizures in children generally is from febrile seizure, what we used to call febrile convulsion. So the remaining 40% is now between epilepsy and this acute symptomatic seizure. So among the afebrile causes of seizure, 40% of them are from acute symptomatic seizure, while the remaining is from unprovoked seizures like epilepsy. Age and specific incidence of acute symptomatic seizure has been, different incidences have been recorded in different studies, which could relate from, which could derive from the kind of underlying etiologic factors, like in places where there are a lot of congenital anomalies and congenital anomalies of the brain, then you expect that the incidence there will align with the all those structural abnormalities like the neurocutaneous syndromes, like vascular malformations of the brain and the rest of them. Now, in our population where we have a lot of there are blacks and hemoglobinopathies, which is commoner among Black population, you might find sickle cell anemia, with the seizures that come with it, be it from stroke, be it from the hypoxic state that the sickle or the ICAM molecules will bring about at the level of the brain. All of them will give you different incidences in different populations. So that will explain why we have a wide range of incidents between 29 and 39. You can see how wide it is. So within the first year of life, in infants, you have the highest incidence of acute symptomatic seizure. So whenever you're seeing an infant in your practice, try not to just say, this child is having seizure, it's epilepsy, you now start anticonvulsant, long-term anticonvulsant. If you cool down and try to find the underlying cause of the seizure, you'll be able to prevent the child from having a recurrence of the seizure.
So, like you said, causes of acute symptomatic seizures, it could be structural causes, it could be inflammatory, infection, toxins, and it could also be metabolic causes. So here, example of primary brain insults. We have traumatic brain injury. In this case, traumatic brain injury is actually known as one of the commonest causes of acute symptomatic seizures. Be it somebody hitting their head violently against an object, which in cases of fall, car accident, or spot injuries, it could be from shaking a child's head, violently shaking a child's head in cases of child abuse. It could also be a sharp object piercing the skull in cases of gunshot wound. So depending on the type of and severity of the trauma, the person might experience either brain contusion, intracranial hemorrhage, subarachnoid or subdural hematoma, epidural hematoma. All these things are actually known causes of acute symptomatic seizures. We also have intracranial surgery causing acute symptomatic seizure. The mechanism behind it could be due to acute tissue damage, it could also be due to hypoxia, it could also be due to edema. So we have CNS infection, autoimmune disease, metabolic derangement, which we are going to explain more in these slides.
a CNS infections like meningitis, like meningoencephalitis, like encephalitis, or they will all impinge on the neuronal functions. So the more there is affectation of the neurons, the more likely the signals might be bizarre or abnormal. So autoimmune diseases and metabolic derangements like in this index, hypoxia, electrolyte imbalance, hypernatremia, hyponatremia, hypocalcemia, hypomagnesemia, or even hypoglycemia can give you seizures, in which case we say the seizure is acute symptomatic. Okay, so the structural abnormality in the brain, like stroke, do hematologists will query in this index if a child with sickle cell anemia is having a seizure, it might be a pointer to a stroke or impending stroke. So some hematologists will argue that, are you sure this child don't have a stroke? So we did the transcranial Doppler that helped us to also, because we were also thinking in that line, but with the findings of the transcranial Doppler. It wasn't possible for us to do HB quantification to know if the S window is high. If the S window was more than 50%, we would have also thought of the possibility of an impending stroke from the increased viscosity of the sickled red cells, because the newer finding shows that not just like the red cells that will sickle blocking blood vessels will cause problems, but now there is also increased agglutination of not just the red cells now, platelets, even the endothelial lining can be a very good place where some of these cells will get attached to and impede the free blood flow. Brain tumors can impinge on the nerves in the brain and cause seizure. Congenital birth defect, especially those involving the central nervous system in the brain, can lead to seizures. Children with neurocutaneous syndrome, tuberous sclerosis, Sturge-Weber syndrome, where you have some structural lesions in the brain, present with seizures. So those seizures will not be categorized as epilepsy. Those seizures should be categorized as acute symptomatic seizure, because once you take out the underlying etiology or the underlying cause, most times the seizures will see subarachnoid hemorrhage because of how the blood that has accumulated in the subarachnoid space impinges on the nerve in the brain, and it also leads to seizures.
So metabolic causes of seizure,
But let's see whether there are other contributions from our participants. Okay, it's still okay. We say, your voice is low, so let's.
So we also have metabolic insults causing acute symptomatic seizure, which is also commonly encountered in clinical practice. For example, be it hypoglycemia, be it hyponatremia, hyponatremia, hyperglycemia. They're all known causes of seizures in clinical practice. So acute and severe electrolyte imbalance can exhibit progressive neurological symptoms, including seizures, and we can see them in cases of hyponatremia, hypoglycemia, hypomagnesemia, and hyperglycemia. So normal value for sodium is 135 to 145. Anything below 135 is hyponatremia. However, for hyponatremia to put a patient at risk of 120. So that's when the brain will start to swell, you are at risk of herniation and having acute symptoms. So we also have hyperglycemia causing seizures. This one is in a case where, in cases of hyperglycemia, there is decreased GABA receptors, and GABA is known to decrease stimulation of the nerve cells. So when your GABA receptors are below normal, that means your neurons will be firing more than normal, causing seizures in cases of hyperglycemia. We also have hyperglycemia caused by uremia and acute renal failure, thyrotoxicosis, storm, and porphyria. So we have some of our values for glucose level in children. We expect it to be from 40 to 70 milligram per DL. That is normal. Anything below 40 place you on risk of acute symptomatic seizure. We also have our sodium, anything below 120, you're at risk. Magnesium, anything below 0.3. Urea, anything above, in children, urea is not supposed to be above 7. So anything above 35.7 puts you at risk of having acute symptomatic seizure as well. And creatinine as well, 884.
Okay, so some people raise their hands. Let's see what. Okay, there's no. So if you have any concern or you want to make contributions, just put it up in the Q&A section so that in the course of the discussion we'll look at it and also talk about those concerns. So she has mentioned most of the, I want to explain why these values are there, because people that are very current with the cutoff of some of these values will argue that hypoglycemia, why are you putting less than 40 milligram per DL when the latest literature is suggesting it in less than 50? Well, there's a difference between asymptomatic hypoglycemia and hypoglycemia with neuronal symptoms, what we call neuroglycopenia. When the level of glucose in the central nervous system is low, it can cause seizures. So the level of blood sugar that you expect neuroglycopenia is anything below 40 milligram per DL. So if the child's blood sugar is more than 40 milligram per DL, just widen your search, look at other things. There could be other reasons why the child could be convulsing, not necessarily because of low sugar level. So sodium, Dr. Fatima has mentioned the levels of hyponatremia that should cause seizures, the magnesium, the calcium, and the blood urea nitrogen. Those values are the values beyond which or below which you expect to be the reason why a child might convulse. So let me just talk about some of the infective or inflammatory causes of acute symptomatic seizure. A child that has brain abscess can convulse because of the space occupying effect of the abscess. Now, if there is abscess collection on one part of the brain, to push the brain substance away from the collection. So that pressure effect will impinge on the nerves and cause a focal seizure that will manifest on the contralateral side of the child. So when you see a child with focal seizures or what you call partial seizures, let's say there is an abnormal movement of the left side of the body, left upper limb or left lower limb, it might suggest that there might be a collection of abscess or any other space occupying lesion, blood or any other thing on the right side of the child's cerebral hemisphere. Meningitis can cause seizures because of how the inflammatory changes, the pro-inflammatory cascade that is happening within the meninges. These pro-inflammatory changes will make the blood-brain barrier to be very porous, allowing a lot of things to go in. And these things that pass the blood-brain barrier can be irritants to the central nervous system, including the nerves of the child, causing acute symptomatic seizure. So for a child with meningitis, you have to treat the infection by giving meningitic dose of antibiotics, steroids like dexamethasone needs to be given prior or with the first dose of the antibiotics so as to stabilize the membrane, so that the pro-inflammatory changes, with the cytokines and other things that can destroy the tissues there, don't end up leaving the child with some neurologic sequelae that the child will now start battling. Encephalitis, HIV/AIDS. HIV/AIDS is one condition that can present with a constellation of problems, including opportunistic infections that equally affect the brain and cause seizures as well. Severe malaria or cerebral malaria present with multiple seizures. If you see a child that is unconscious, unrousably comatose, that has repeated, seizures or repeated convulsions, that child might be having cerebral malaria, in which case you have to show that there are demonstrable asexual forms of P. falciparum, which is one of the commonest species of malaria parasite that causes that. And once you start anti-malaria for them, despite the deep nature of the coma, you see the child coming up and doing as if nothing really happened. Febrile illnesses as well can also cause seizure. If there could be sepsis associated encephalopathy, in which case the child will have some CNS features not characteristic of meningitis, but the toxins and other things that are released by the infection or the sepsis can equally cause seizures in this child.
So we also have toxic causes of seizure. So when we talk about the toxic causes, we can talk about basically two important things: alcohol abuse and drug abuse. When do we suspect that someone that is having seizure is due to alcohol? The patient will have history of alcohol abuse. The seizure will occur between 7 hours to 48 hours from his last drink, and then he will have other symptoms of withdrawal such as tremor, confusion, and such. And drugs as well. We know some drugs are also known to cause seizures. Antidepressants, for example, stimulus drugs like cocaine, methamphetamine are also known to cause seizures. So when a patient is on this medication and they have seizure, you can suspect it to be due to a toxic insult. All drugs, tramadol and isoniazid are the account for majority of cases of drugs that actually cause acute symptomatic seizures in pediatric age group.
Okay, I'll want to add at this point, a lot of our adolescents these days, they already know what we know as the common causes of the common substances of abuse. Now there is a cocktail of beverages, candies, like a tom, Maggi and malt, and so many things that they mix together that you will not be able to detect with any toxicology screen. So some of these things can equally present as seizures. When you see an adolescent presenting with seizures that doesn't really add up, maybe the child was in school, then when he's done with his exams and he's at home, he now develops seizures. Those seizures could be a sign of withdrawal syndrome. A child has been taking tramadol or any of those psychoactive substances and is at home, not allowed to go out to mix up with his friends, where he will probably get some of these materials, might start having seizures. And if you don't probe deeply or just ask them some specific questions, you may be thinking that the child has epilepsy, not knowing that the child is not able to get what usually makes him feel high. And until you're able to offer them some, cognitive behavioral therapy and some psychotherapy, the seizure may continue for a while. So this should be at the back of our mind while we try to unravel or fathom the likely causation of the seizure a child is having. So the diagnosis of acute symptomatic seizure from the discussion we've had has to be derived from a detailed history. You need to take your time to find out the likely underlying etiology or the underlying cause of the seizure. The index patient we presented was a known HBSS that had low oxygen saturation. So if you're able to, because of the history, able to know that possibly because of the hemoglobinopathy the child had, the child could be at risk of having low oxygen tension, especially when there is when the child has one form of crisis, anemic crisis or any other crisis as it were. So detailed history is important. And the seizure profile, the same what we call semiology of the seizure is equally important. The nature of this, if the seizure is one-sided, is manifesting in one side of the body, you think of a space of point lesion on the contralateral part of the brain. Now, if the seizure is myoclonic or the seizure is very difficult to abort, you also think of the possibilities of a metabolic cause of the seizure, because most metabolic causes of seizures are difficult to control. If a child is having hypoglycemia and you give all the anticonvulsants you like until you correct that low blood sugar, the seizure might unlikely stop. If a child like in this index, with the hypoxia of its, the child had oxygen saturation of 86%. If we are not giving intranasal oxygen and we are giving all the anticonvulsants, the convulsion will continue. Now, after getting a detailed history, a thorough focused physical examination should be done, especially neurological evaluation, because when you do a neurological evaluation, you'll be able to know whether there is meningitis, for instance, signs of meningeal irritation, upper tract signs like brisk hypertonia, brisk diptendal reflexes, and that will tell you what exactly is going on. If there is meningitis, you'll be able to know. If there is sepsis, you'll be able to know. If there are other things of other causes of cerebritis, you'll be able to know, and that should guide the investigations you request for the child in question. So it's not every child that comes that you now list all the possible causes of acute symptomatic seizure. You do random blood sugar check. If the child, had not eaten, let's say the last meal of the child was the day, maybe the afternoon of the previous day before presentation, a random blood sugar check would be important, because that could tell you the likely cause of the seizure. If a child has been passing loose stool, has had several episodes, more than 5 episodes of loose stools, then if serum electrolyte urea creatinine will tell you if there is electrolyte imbalance as being the cause of the seizure. If there are things like fever, convulsion, or that consciousness, a sepsis screen can help you know the likely cause of the infection and also guide your treatment in finding. So we want to talk about, most times when a child is having a seizure, it's not usually the seizure that is the problem, because most seizures within 5 minutes abort spontaneously. So it's what is done to a child that is convulsing that will eventually lead to a problem that may be difficult to sort out. Let's say a child is convulsing, you carry onion juice or all those corrosive materials and put in the eye. You try to force the mouth open. Let's say in the process of trying to force the mouth open with a spoon, you remove any of the tooth of the child. Now, when that happens, that tooth can actually enter the airway and cause obstruction of the airway that will lead to lung collapse. That lung collapse will cause a more life-threatening problem than the seizure that will just stop after a very short time. So we should know that if a child is convulsing, one of the things to do is to ensure that the child is safe. If somebody falls by the wayside where there are vehicles, you remove the person from harm's way, ensure that the airway is patent, then lie the child on the left lateral position and stay with the child until the seizure resolves. If there's any harmful thing around the child, remove it, because those harmful things while the child is convulsing can, cause an injury to the child that, you will not start thinking of how to sort it. While you stay with the child, you call for help. Once the help arrives, you take the child to a facility or a hospital where the child's problem will be properly managed. At the level when we see mothers come to us, or maybe our relatives asking us if a child is convulsing, what do we do? You tell them the things they should do at home, like removing any harmful things, stay with them, call for help, and bring them to the hospital. While in the hospital, we also talk about the things we medical personnel can do to a child convulsing. If a child is convulsing, most times within 5 minutes to resolve. But it will be criminal for you to have a child come to you convulsing and you stand watching to time how. I remember those days in medical school. When you're taught about status seizure that has lasted for up to 30 minutes, or the child is convulsing, and in between there's altered consciousness, and the child doesn't recover from the unconscious state in between the seizure. So if a child is convulsing and you wait for the convulsion to stop, timing your watch, and once it's 30 minutes, you shout, "Eureka, I've made a diagnosis of acute symptomatic seizure." The longer the seizure, the more brain damage the child will have. Cerebral edema, hypoxic injuries, cytotoxic injuries that will leave a permanent, more debilitating neurologic sequelae that the child will live with. So once the child presents to us, we'll talk about some of the medications that can be given when a child presents to us convulsing. So we've talked about all this.
So this image summarizes
okay.
the first care management to do when a patient is having seizure, when somebody is having seizure. First of all, you have to stay with the person, like you said, and time the seizure, because timing of the seizure is very important for the medical team that are going to step in and take care of the patient. And then keep the patient safe, avoid and remove the child from any harm's way. If he's in the kitchen near fire, on the side of the road or somewhere dangerous, just make sure he's in a place where he's safe. And turn the patient onto the side. You turn the patient to his lateral side so that tilt his neck 30 degrees. That way you can help avoid aspiration. Do not put anything in his mouth. Do not give him water, pills, food, or anything. And do not restrain. Stay with them until medical help arrives. Normally, seizures, like we said, will abort itself within 5 minutes. In case it doesn't, then just stay with him until the seizure subsides or a medical personnel is there to take care of him.
So let's check if there are other. Okay. Somebody just made comment about cerebral malaria causing upper sensory, not unconsciousness. Okay. Well, I don't know the person that is putting on this, but there is a difference between severe malaria with altered consciousness, because altered consciousness was added in the year 2000 to the subsets of that's in some of the components of severe malaria. There could be severe malaria with altered consciousness. But when you say cerebral malaria is a diagnosis on its own that has some specific things. Altered, unrousable coma is there, demonstrable asexual forms of parasite, and you've excluded other causes of acute encephalopathies. So cerebral malaria is a component of severe malaria. Altered consciousness or impaired consciousness is also a component, because there are children that might have severe malaria with impaired consciousness that will not fit into the categorization of cerebral malaria. There are other things in cerebral malaria that, beyond just the clinical findings, there has to be the level of parasitemia that should get to the brain and cause some of the problems that will cause multiple seizures in the child. Then there are also things that pathologists will find in the brain of the child that will tell you this child possibly, well, that one is post-mortem, that will tell you that this child had cerebral malaria or probably died from cerebral malaria. So those are some of the things that if you don't read the the literature very well, you may not know some of the differences of the when you say the cerebral malaria and when severe malaria with altered consciousness. So I think that should be able to put that to rest. There is no other additional comments or contributions. So let's write on. So the medical care, okay. If a child is convulsing, these are basic medical knowledge or information that we are all taught in medical school. If somebody is convulsing, ensure you have, this an emergency. So you have to follow the ABC of resuscitation. A, ensure that the airway is patent. If there are things, maybe secretions and all that, which will impair the oxygen supply to the lungs, you clear the airway, suction, ensure that the child is breathing, then ensure adequate circulation. But when we now get to D, that's where we need to ensure that the drugs, any deformity is corrected. If there is hypoglycemia, as you're in the C, while you're securing IVR cells, collecting sample, you check blood sugar. If the blood sugar is low, you correct, because hypoglycemia can cause seizure. Once you correct hypoglycemia, or if hypoglycemia is the cause of the seizure will abort, and you maintain to ensure euglycemia. And if that is done, there won't be any repeat episode. As you're collecting your blood, the patient's blood, you also ensure that you send the samples for serum electrolyte and creatinine. For a child that has been passing those two, stooling and vomiting, you try to look at the sodium level, look at the potassium level. If the child has lactose intolerance, maybe the child has not been taking milk, which is the commonest or richest source of calcium in our environment, that child might have hypocalcemia as being because of the seizure. So you need to do serum electrolytes, calcium, and magnesium. That will show you if magnesium or calcium, low levels of these electrolytes, is responsible for the seizures the child is having. Now for the okay, you can check the oxygen saturation using a pulse oximeter. Like in this index that the saturation was 86%. Just give intranasal supplemental oxygen. Once the oxygen saturation normalizes, the seizure will abort. Now, if a child presents to you now convulsing, we have to abort the seizure. A number of things can be used to abort seizure. You can use IV diazepam at 0.3 milligram per kg start to abort the seizure. Or you can use rectal diazepam 0.5 milligram per kg. You have rectal diazepam, there's no diazepam that comes as a suppository. It's the same diazepam. You check the weight of the child. If the child is convulsing at the time, you won't start saying, let me check the weight. From the age of the child, like a 1-year-old should weigh 10 kg. From the weight of the child, you know that a 1-year-old child weighing 10 kg should receive like 5 milligrams of rectal diazepam. So you draw the diazepam in a syringe. One ampoule is 10 milligrams. So half of it should be 5 milligrams. So put it in a syringe, remove the needle, don't put the needle on the syringe. Just put the syringe through the anus, the anal sphincter, and push the drug through the anus. Hold the gluteal, the buttocks of the child together, hold it for like 2 to 3 minutes, then gently remove the syringe. Once you do that, the seizure will abort. IM paradihide can equally be used. The dose is 1 ml per year of life, or 0.1 ml per kg per dose IM. So that can equally be used. Or you can use rectal paradihide, 0.3 ml per kg in equal dilution with olive oil. Push it through and just as you would give rectal diazepam. The other things, depending on what is available, most times when you use any of these two medications, the seizures will abort. But in case you use these two and seizures don't abort, you might be dealing with a status seizure. A seizure that, in fact, most seizures that last beyond 5 minutes are unlikely to stop. So that's why the classification of status seizure now, we've come down from 30 minutes to 5 minutes. Any seizure that lasts more than 5 minutes is a status seizure because it's unlikely to stop unless you do something. So for the ones that fail to abort with diazepam or paradihide, you can use phenytoin. Phenytoin, the dose is 5 milligrams per kg. You can give starts, then maintain. If there is a recurrent episode of like meningitis, cerebral malaria, the seizures can be recurrent. While you're treating the underlying cause of the seizure, place them on a short course anticonvulsant using the phenytoin sodium, 5 milligrams per kg in 2 divided doses for 5 days. While you're treating, within these 5 days, once the cause of the seizure is sorted out, the seizure will not recur. Then if phenytoin fails, you can go to IV diazepam, 5 milligrams per kg in 2 divided doses. You can give a loading dose, 10 milligrams per kg starts, then maintain on the 5 milligrams per kg in 2 divided doses. Remember, if you're giving the phenobarb at that loading dose, make sure that you have your bag and mask ready in case there is a respiratory depression, so that you help assist the child with breathing while the drug, the half-life of the drug wanes for the child to commence. For those that even fail to respond to phenobarb, we can invite the anesthesiologist, move the child to ICU, where thiopentone, propofol. Please, let's not take the route of Dr. Conrad giving propofol at home. Remember the story of Michael Jackson and Dr. Conrad that gave propofol while the young man was at home, and guess what? He went from there. So please, let's just ensure if we can apply these simple measures to our practice, the outcome will be so wonderful, and our guests or patients, depending on the nomenclature you call your patients by, will have very good outcomes. So let's check for other contributions or comments. Please, is it the same vial on which they write IVIM? That's a pump that is given per rectum. Yes, it's the same. It's the same, but the dose for IV is different from the dose for rectal. The dose for IV is 0.3 milligrams per kg. Remember, you need to dilute it. Most times, if in the course of the emergency, you're not very sure of what the weight is, you might, if you go and give a dose that is so high or too much for the child might go into respiratory depression. So we usually advise that you doubly dilute the diazepam and give it slowly. As you're giving it slowly, once you get the desired effect of aborting the seizure, you stop at that point. You mustn't give everything, but the dose for IV is 0.3 milligrams per kg, while that of rectal is 0.5 milligrams per kg. What's the difference between the onset of action of rectal and IV? Okay, so anything you give intravenously will have a faster onset, But the one you give in the rectum, depending on the nature of hydration of the child, a child that has been passing those two dehydrated, there's what we call diving reflex. Most blood supply to the digestive tract will be channeled to the brain, the heart, and the adrenals. So the absorption might be impaired. So usually IV is better. But if the child is convulsing and securing the limelight, it's a bit difficult. Just do the right time. It might take a while, but it will still give you the desired result. Please kindly help us outline this management guideline in this slide for revision. Okay, we'll do that when we are sending the slides to our participants. So I don't know if there are other comments or contributions or that we've ended up. If there is nobody is commenting commenting again, it tells me one or two things. Either that the presentation is so simple and understandable, or we have ended up confusing everybody. I don't know which one it is. I think it's the first one. Please, the presentation is so clear and straightforward. So I believe we've been able to unravel what acute symptomatic seizures are. So we expect that if any child presents to us with seizures of acute onset, we should not be in a hurry to say this is epilepsy. Or even if the child is having fever and convulses. No fever convulsion is a diagnosis of exclusion. We don't say, okay, a child that is between 6 months and 5 years that is convulsing with fever is a febrile convulsion. Just go a step further to try to find out why this child is convulsing. By the time you're able to rule out any metabolic imbalance, any structural brain damage, any possibilities of low sugar level, electrolyte imbalance, congenital anomalies of the brain, or any of the other aforementioned causation of acute symptomatic seizure. You can now say, okay, is either this child is having an unprovoked seizure or the child is having a febrile seizure. So early identification of the etiology is important. I think we need to mention at this point that there is also this overlap between acute symptomatic seizure and a later life epilepsy. If acute symptomatic seizure is not managed well, let's say a child had meningitis and it wasn't well managed, that child can have a long-term epileptic seizures. If a child has a structural brain problem that is not sorted out, the child might end up having epilepsy. A child that has complex febrile seizures has a risk of later life epilepsy if it's not well taken care of. So acute symptomatic seizure, how you manage it is different from how you manage epilepsy or febrile convulsion. Febrile convulsion is fever, either the rate of rise or rate of fall of the fever that is causing. If you manage the fever well, you're good. For acute symptomatic seizure, the underlying cause needs to be managed. If not, the seizure will continue. And if it continues unabated, there could be a long-term neurologic sequelae, which can even manifest as epilepsy. So acute symptomatic seizure may unlikely recur if you take care of the underlying cause. And we've talked about this subsequent risk of epilepsy. So please, dear colleagues, at this point, I want to crave our indulgences. Let's just try and be intentional when we see children with seizures. When they present to us with seizures, let's try to unravel why they are having the convulsion. If we're able to do that, the later long-term sequelae may not even arise in the first instance. Thank you very much for joining us for this month's webinar. We believe that we've been able to unravel acute symptomatic seizures, and going forward, we'll be able to manage our guests better when they present to us in our practice. Thank you. Thank you. Thank you. Okay, so if there are other questions that you want to ask, please put it up on the chat box, okay, so that we can. Okay, so what are the likely complications of a child with seizures? Okay, so a child with recurrent seizures, you know, the more the child is convulsing, the more there could be cerebral edema. In fact, if a child is having recurrent seizures, some of them might even regress on their milestones. There's what we call epileptic encephalopathy. If a child is having recurrent seizures and is not aborted and is not treated, the child might lose milestones like even motor milestones, speech milestones, and all that. So that's why we need to take it very seriously. Cerebral edema, and cytotoxic edema, and the rest of them can happen in the course of the seizure, and this might lead to a very untoward complication. Please can diazepam be an option despite erratic absorption? Okay, so I have mentioned the challenge with rectal diazepam. A child that is convulsing, maybe there's a tonic-clonic seizures involving the lower limb. I don't know how you hold that child's thigh, steady the leg and start putting, a needle through the muscle. Another thing is a child that has been passing those two, that is dehydrated, blood supply to the muscles will be impaired. What the body is bothered about at that point is to ensure that the brain, the heart, and the adrenals get well infused. So the absorption may be delayed. So you want something that is fast onset, rapid acting to abort the seizure. So rectal or IV is usually advocated. Is there no provision for nursing care in this condition? Well, we are just focused on acute symptomatic seizure, what to do, okay, what is causing it, so that we'll make the diagnosis and how to abort the seizures when it happens. We mentioned as we try to talk about what to do if a child is convulsing. We talked about how the child should be nursed while the seizure is happening, the positioning, how to tilt the head up a bit by 30 degrees, keeping on the left side, and all that. There is provision for nursing care, but for the purposes of this discussion, we wouldn't want to go that route. Maybe in one of our Instagram live, when we bring our nurses on board, maybe we can consider talking about nursing care. Okay, Raphael said it's very clear. Okay, thank you for the elaborate lecture. Kindly throw more light on how to tell apart seizures from infective, inflammatory causes to give fever, febrile convulsion. Okay. So I thought we talked about this. I don't know the points at which so anonymous attendee joined the discussion. Okay, so febrile seizure is there's a reason why International League Against Epilepsy try to classify febrile seizures differently. Your target there is controlling the fever. Once you control the fever, you can sort out the whatever that is causing the fever. But in acute symptomatic seizure, what is causing the seizure is the infection or the electrolyte imbalance or the toxin or the structural insults or structural abnormalities in the brain. So your focus here is more on what is causing it. So that's a way of distinguishing. Malaria can cause febrile convulsion in a child between 6 months and 5 years. However, it's not the malaria per se, because the child can have fever, take oral malaria drug, and fever will go. But it's the rate of rise of the fever or the rate of fall. If a child is having fever and you're using cold water to sponge the child, that rapid drop of the temperature can cause seizure. So there you try to ensure that it's tepid water that is used that will gradually bring down the temperature, not forcing it down. So that's a bit, a different approach. It's just the approach to management that is slightly different, although you can actually have, an overlap. So I think that will be a guide, for our clinicians when we have patients present to us with seizures. What are the likely complications in a child? I think we talked about that. Thank you very much for this lecture. Thank you for the presentation. Does magnesium sulfate have a role in hypothesis? Yes, it does. But when you're giving magnesium sulfate, it's not like you have to be very, very careful, because magnesium sulfate can cause weakening of the diaphragmatic muscles. So as you're giving and you find that the respiratory rate has dropped, you won't say, Dr. Nwala and Dr. Fatima said magnesium sulfate can be given, and you now give it. So in acute symptomatic seizure, we are more interested in stopping the seizure. And the best way to stop this seizure is by giving those drugs that we've mentioned. Diazepam, formaldehyde. Then when those two drugs fail to help, you can think of phenytoin, phenobarb, and the other ones. But basically, magnesium sulfate is not what we are thinking at this point, because if you're giving magnesium sulfate, then there is now some of the weakening of the muscles, including the respiratory efforts of the child. You now start looking for ventilatory support for the child. So let's just leave that for cases that will require that. There are conditions that we'll think of giving magnesium sulfate, but let's just limit ourselves to these common medications that will help us achieve seizure control as fast as possible. Click the link below to join. Okay, so thank you for the lecture. I wanted to clarify the reason why HbA1c was done. Okay. Now, in a child with hemoglobinopathy, one of the risks of a stroke. In fact, the commonest cause of stroke among children is sickle cell disease or sickle cell anemia, depending on which school of thought you belong to. Now, if there are so many, if the concentration of the sickle cells, is actually above 50%, it will lead to viscosity of the blood and eventually lead to stroke. So a child that is having seizures, a child with hemoglobinopathy with seizures, you need to be sure that it's not the increased viscosity of the brain that has clogged some cerebral vessels that is responsible. In which case, what you will do for the child will be to do exchange blood transfusion. Exchange blood transfusion, if the HB is above a certain level, depending on the facility, some people use levels above 27% PCV, they do exchange. Below 27%, they do simple transfusion first before exchange. Some other places, you use 30% PCV, above 30%, you do exchange. Below 30%, you do simple transfusion to optimize it before you do exchange. Now, if the S window, if the concentration of hemoglobin S is high, what you need to do is to bring it to below 50. Some ideally should be below 30%. So chronic transfusion may be indicated to ensure that the level stays below that level. Because if it's above 50%, there is the risk of seizures, there's the risk of stroke or impending stroke in the child. So that was why we also looked at the HB quantification, just to be sure that what is causing seizure in the child is not an impending stroke or a stroke as it were. So although we are not able to get that done, that would have helped us further with that. But the transcranial Doppler was able to help us, please, direct our search elsewhere, not to focus on the HB quantification, as in the hemoglobin S level being responsible for that. Thank you. I appreciate the look. Said say thank you. Please, why are we diluting rectal paradehyde with olive oil? Okay. So the drug. I don't know whether if you've used the paradehyde, you know what it does to rubber plastic syringe. If you draw paradehyde in a syringe and you don't give it immediately, it will just seal, it will just make it to mats together, the plunger and the syringe itself. You won't be able to push it out. So paradehyde can be an irritant. It can irritate the rectal mucosa. So you want to dilute it so that irritant effect is reduced. It will still be absorbed by thorax, but if you push it in that concentrated form, it might cause some problems for you. Thank you. I think that does it. Thank you for your participatory listenership. We are so glad to have our colleagues join us for this month's webinar. Watch out in your emails for the next webinar for next month, the topic and the discussants, so that you plan ahead and enjoy another interesting topic from the stables of Limi Hospital Group. And from me, Dr. Nwala Gabriel, thank you, and have a wonderful weekend ahead. Dr. Fatima.
Thank you very much, and have a nice day.
Thank you. Okay, so if there are other questions you have, just keep them dropping while we take further.
Wonderful presentation, Dr. Gabriel and Dr. Fatima. This is well explanatory. I learned one or two things from your presentation. Thank you so much for your impactful session today. Once again, I'm Pamela Ohaneje, Corporate Relations, and I just want to recap my presentation earlier. For those of us that joined after I presented, still going to give a brief presentation about the Limi Children's Hospital. Limi Children's Hospital is an arm of the Limi Hospital Group located at 39 Ademola Adetokunbo, Wuse 2, Abuja. A designated branch of the Limi Hospital specialized in pediatrics, neonatology, and general medical care for children. And by the way, if you still have questions, just keep it dropping. When I'm done, I'll still hand over the mic to Dr. Gabriel to answer any of the questions you might have regarding the presentation that was just concluded. Okay, so moving forward, maybe you have a patient to share with him regarding what we did today, or other cases relating to pediatrics generally. I just want to notify each and every one of us that we are available for collaborations, partnerships, referrals that can come from you as a personal physician, as a consultant, or as a hospital. Like I mentioned, we have an ongoing partnership with a lot of hospitals, government hospitals, private hospitals, and a lot of MOU have been signed for research and collaborative purposes. So this opportunity is available to all of you on our platform. So in terms of referral, a lot of referral incentives that you can benefit from as a referring physician to the Limit Children Hospital. So aside from that, there are also benefits because we have a team of consultants in all medical specialties relating to pediatrics. We also send detailed back referral medical reports to the referring doctor. So I plead with you to include your number, include your email, include your hospital address if you're referring to Limit Children Hospital, because we use this information to write a detailed report back to you. We manage your patients and we send them back to you. And then we'll also send you a detailed feedback referral report so you can be carried along as to what was done, the diagnosis, the management, and the overall caregiving to each and every one of your patients. And then, okay, we also have an opportunity to discuss and collaborate with a team that referred. So the doctor that managed your patient, his number will be available in the medical feedback referral reports. You can call, you can reach out to him to get more insight on what was done so you can continue with a follow-up care. We have 24/7 emergency and same day, next day appointments available, including for our mobile incubator. We also have comprehensive neonatal care and management units, of which is one of our major specialty in the Limit Children Hospital. For babies that are born and they need to be referred as a neonate, we have mobile incubator that can come from from wherever within Abuja, pick these babies and refer them or bring them to wherever they are supposed to be resuscitated. And then we have access to fully computerized system. So there is a unique EMR number that is given to every patient that can be used to track their records and what was done. And it's through this EMR that we gather all the history of diagnosis and everything that was done in the hospital and sent to the referring physician. So for referral, you can refer through any of the numbers 080-905-99994, or you can reach us on WhatsApp on 0909-2429-4618, 090-2429-4618. Our email options is also open. You can still refer via mail, limitchildrenhospital@gmail.com. Our hospital branch still remains 39 Ademola de Tokumbo Crescent, Wuse 2, and we're very open to working with you. We are very open to partnering with you. We are very open to collaborating with you. And thank you so very much for tuning in and listening to this episode of our monthly webinar. Thank you. My name still remains Pamela Ohaneji.
Thank you very much, our wonderful participants. We want to say a very big thank you for your patience, even when we didn't start on schedule. You stayed on and stayed through the course of the discussion. Thank you, and we look forward to having you again. Join us. Same platform for another wonderful and engaging and enlightening topic. Thank you and stay blessed. Have a wonderful rest of your weekend. Thank you.
The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.